Let's do it.
Welcome back to the Sickle Cell podcast. It's Cass here, and I'm honored to be joined by a very special guest, Dr. Julie Kanter. She has devoted her career to improving care for individuals living with sickle cell disease across their lifespan. So I want to transition over to treatment options. And, it's a big topic for adults with sickle cell. Some of the questions that we get most from the community is, what's out there to build blood? What's out there to decrease pain? What's out there to make my eyes not yellow? So, how should adult patients and providers decide what treatment options are best for them?
Such a great question. So one thing I'll say is if you're at a NASCC center and somebody asks if you want to be part of our registry called Granddad, and I'm going to tell you why this is so important, please say yes. One of the reasons that we in the sickle cell world are not as good as personalizing treatment is that we have not done a good job of creating a national registry. That longitudinal registry would, if I had that now, I could look at your profile and say, yes, you're going to be a good hydroxyurea responder, or maybe it's not the drug for you. At this point, we're not there yet, but it's how you as an individual contribute to getting us there. It's the most important thing is collecting longitudinal data because we want to be able to personalize your care. Right now, and I know people hate it, but there is some trial and error to it. We just don't have that data. So I would say that 90% of us are going to offer hydroxyurea regardless of who you are when you walk in the door, because it is the best drug we have available to us. And we need to educate people better about how to take it, when to take it, all those things. But it is one of the best drugs, but it is absolutely not for everybody. And that is 100% true. And I do think there are colleagues that I work with that need to hear that more often. There are people who don't tolerate it. The people who I've had a couple of adults who have terrible fatigue with it. What I've learned over time is starting low dose is really helpful as opposed to starting on a higher dose. And that's not kind of sometimes what we were trained to do. But it is a great option. It will help you gain weight. It will help your eyes not be yellow, and it will slowly help your hemoglobin be a little bit higher. In terms of other options, I know there's still debate, and there's a new study going on crizanlizumab that I'm really excited about, but I actually think for some people it's a great drug. And when we look, we see that about 30% people respond really well, which means they have significant decrease in acute pain crisis. And that was a study we presented a little while ago at an ASH. But 30% are kind of in the middle, and about 30% of people actually get worse. And one of the things that I saw that really upset me is I had a community doctor who was basically crizanlizumab and voxelotor came out and they put everybody on it, and they really didn't pay attention to individual response. And I would love to tell you I was kidding, but I'm not kidding. And when some people got worse, the doctor assumed that they were lying, or I don't know what, but they were missing that. So again, it's super important that's the other reason we like to have these periodic visits is if I start a new therapy, I'm not going to say see you in a year, right? I'm going to say maybe see you in a month or 2 months, and then slowly span that back out because I want to make sure it works for you. So for some people, it works really well. It is also the single best drug I've ever seen for priapism for men at preventing and reducing the incidence of priapism. After that, it gets a little more tricky these days. A lot of people have asked about L-glutamine. Pharmacy grade L-glutamine, so as known as Endari, is also a really good option. Some people do incredibly well with it. It works as an antioxidant. So one of the things that's hard about it is you can't see it in the blood. You can't see the effect of it. It's not going to make your eyes less jaundiced or less yellow. But you'll notice over time that you feel more energized. And slowly it'll decrease the number of acute events you have. But it is harder to measure in terms of efficacy. The other thing that I think is hard is, well, obviously it's ridiculously expensive, and we don't have enough options to get that price down. I also think, and a lot of my patients tell me, it's hard to take a powder twice a day every day, and I totally get that. And so I think we need to still continue to work on how we can improve this treatment. Then there's blood transfusions. right? It's still our, next to hydroxyurea, blood is our very best disease modifier. And that's whether we need simple transfusions or exchanges. We're working really hard to get exchanges better and better for people so that we can give you healthy non-sickle cell containing blood with less iron. And that is an option, especially if you've had organ dysfunction, if you have significant brain, like a stroke or a big risk of stroke, or if you're somebody who's had repeated acute chest. I was actually having a conversation this morning with another doctor about a patient, and she said, and he's a patient, we're going to talk about iron overload next, but he has very bad iron overload. She said, well, why wouldn't you just put him back on his hydroxyurea? And I said, because he took his hydroxyurea, he did everything he was supposed to, he had very high fetal hemoglobin, but he still kept having a really severe acute chest and ending up in the ICU. And when we started him on transfusions, it was miraculous. Not only did he not have pain crisis at all anymore, but he actually didn't have these terrible, horrible acute chest episodes that become life-threatening. And so now we're going to talk about iron overload. I know iron overload is miserable, and I know you can't feel it and you get fussed at by us a lot. But seeing people die of iron overload is one of the hardest things I've ever done. Because, you know, as humans, we're not good at preventative care. Doesn't matter who we are reactive. It's hard to do something because it's going to help you when you can't see it, feel it, taste it, right? And that's how iron overload is. But when it's bad, we can't often get back. We can't fix it. And so if you are taking JADNU or supposed to be taking JADNU, if you're having GI issues, talk to your doctor. There's some other options out there. And I am working with some companies on some other options that may be available, because these are hard therapies to take, but so important to keeping you healthy.
So I have hydroxyurea, crizanlizumab, L-glutamine, blood transfusion or exchange transfusion, and then if you are on blood transfusion or transfusion, then JADNU.
Chelation. That's the fancy word.
Iron chelation.
Yes.
Does that sound about right to you?
Yeah, there is two other iron chelation medicines we don't talk about enough. One is called deferiprone, or its trade name is Feraprox. Yeah. And I should not use trade names. I just cannot say the other name for JADNU very well, Deceraferax. I'm sure I still said it wrong. And then there's Desferal, which are the infusions. So there are other options. And again, hopefully finding some more. And then, of course, there's folic acid, which I don't think you really need to take every day of your life. You need to take it a lot, but probably not every day. Some people still need vitamin B12. That's another thing that's possibly out there. And then one of the other medicines we don't talk about enough is erythropoietin, or its trade name, one of the many, is Procrit. And what this does help your body make more blood. And we have to use it somewhat gently is the best way I would think about it. Again, it's very personalized. And what I've learned is that, taking this back a little bit, people with bad kidney disease or significant chronic kidney disease need it because your kidneys are where your body senses how much blood you have. And when your blood is low, your kidneys say, I'm going to need more, and you make the hormone erythropoietin. But people with sickle cell, as you might imagine, need more blood than the average person. And so their levels are higher. And many kidney doctors just don't understand this. And so they underdose the erythropoietin, and it is a shot, which is annoying, or they use a long-acting version because it's better covered by Medicare and because it's easier. I
anticipate that a lot of what you said resonates with people. So if they wanted to get connected with you, what is the best way?
Kanter at sicklecellcenters.org.
Well, thank you so much, Dr. Julie Kanter, for having this important conversation today.
Thank you to you, the Sickle Cell community,
for inspiring us, partnering with us,
and giving us the opportunity to stand with you, for you.
Our Vertex teams around the globe are proud to be working on sickle cell disease
in hopes of advancing innovative ideas and to make a difference.
And our progress so far is just the beginning.
As we expand our work in this space, we remain committed to our goal
of having a transformative impact on people living with sickle cell disease.
And we continue to stand by your side.